Hi there, my name's Jackson Hicks, and I'm here to talk about prescription drug monitoring programs and the opioid epidemic. The problem in question is obviously the opioid epidemic itself. Opioid overdoses are a leading cause of accidental death in the United States. Overdose deaths with prescription opioids make up about 20,000 of the 52,000 lethal overdoses in 2015. Heroin makes up an additional 13,000 of those, making opioid overdoses as a whole a majority of the overdose deaths in 2015. The overdose death rate in 2008 is nearly 4 times what it was in 1999, showing that opioid abuse and the deaths that result in it are not a problem that are going to go away if ignored. This is a rising problem. In addition, an overwhelming number of heroin users in opioid addiction treatment, about 94% of them, began using heroin because they were addicted, but prescription opioids were too hard to get. The specific policy we're going to be evaluating in response to this problem is prescription drug monitoring programs, or PDMPs. These provide information to pharmacists and doctors about who's being prescribed what, how often, when, and where. Some states record this data at the pharmacy site only, others record it at the doctor and the pharmacy, but for this video and the study it's going to be evaluating, these were not functionally different, and so they will be combined. The study in question is Prescription Opioid Usage and Abuse Relationships, an evaluation of state prescription drug monitoring program efficacy by Reisman et al. This uses data from a 7-year period, 97 to 03, from a total of 14 states that report only Schedule 2, 9 states, as well as Schedule 2 and 3, 5 states, drugs to quantify PDMP reporting. These years were chosen for stability in the number of programs, since there was only one PDMP added during the 7-year period, which was Kentucky in 98, which is right at the beginning of the study period. More modern data is available, but as years have gone on, more states have rapidly added on programs such as PDMPs, which would dilute and weaken the statistical conclusions. The study attempts to understand whether PDMPs are successful in reducing the number of those harmed by opioid addiction, and additionally, if the presence of PDMPs impedes doctor performance by making them less likely or less able to prescribe the opioids that are needed by some. The study methods and data. Large amounts of the data reported are from the PDMPs themselves, since their purpose is obviously to track and record opiate use. This study also used the ARCOS database from the DEA to evaluate drug shipments to the various states in question, whether they be the PDMP states or the control states. The year 2000 was included, so we also have access to the census, which will help us more accurately evaluate the populations in question to evaluate whether other confounding factors were at play. Time series linear regression was used to determine if the results of PDMP states versus control states were statistically significant, and multivariate regression was used to break down possible confounding factors such as race, age, sex, and wealth of the populations in question. The results of this study were that states with PDMP programs saw rises in both oxycodone and hydrocodone distribution during this period, but that they remained lower than the control states. Rise in oxycodone shipments was highly correlated with a rise in prescription opioid treatment admission. The gap that existed between PDMP states and control states widened as the study progressed. So at the beginning of the study in 97, PDMP states had a slightly lower rate of admission to treatment programs, and as the years went on, the difference between the two just grew larger and larger. The final conclusion by the study's authors was that PDMPs provide a blunting effect on opioid use, that is, they help slow down the results of the problem without fully fixing it, without overly chilling the ability for doctors to prescribe opioids for their intended use. Other points of discussion here would be that PDMPs are one element of a multi-pronged effort to blunt the opioid epidemic. Other efforts include prescriber education, needle exchanges, naloxone, and Good Samaritan laws. States range from Connecticut, which uses all 5 of these, to Missouri, who's done nothing. And these years were chosen to evaluate PDMPs as a whole, as a concept, rather than to evaluate the efficacy of any one given state's PDMP programs.